Hello there, this is Chapter 5, Communications. So as an EMT out in the field, you will be using various types of radios. The most common is probably going to be the portable radio, the one you see pictured here on the screen. These should be kept with you at all times, whether you're going for a jog or you're running a call or going shopping in the store. While you're on duty, you should have this with you. It has frequencies so you can contact dispatch. It has frequencies you can contact base hospitals and other hospitals as well. It's a great resource for us in case we do get in trouble for some reason. We feel threatened, and or just someone asks for help and you want to request, just additional resources to help you out. Um, they do have what's called a push to talk button. As you can kind of see, the arrow's kind of pointing to a button on the side of the radio. And so what happens is that if you are going to call, let's say, a hospital, you're going to choose that frequency that you want with those knobs on the top of the device. And when you're ready to talk, you're going to push that button in. What it does, it opens up the frequency and it allows you to talk to that radio base station that you're calling. And then once you're done hailing that particular hospital that you're calling, you're going to let go of that button. And that allows the other person on the other side to push their push to talk button so they can talk back. So this is a one-way system. It's not like talking on a telephone. So the FCC basically oversees what we can say on the radio. It also controls what frequencies we're allowed to use for EMS. And I know people think about, well, what if I say a bad word? What if I say the F word? It is an issue, but it's pretty minor. If it's isolated, it's not a big deal. It does happen occasionally. I've heard it myself out in the field. The big issue is patient confidentiality. So if you're talking on the radio and you inadvertently give the patient's full name, their social security number, their date of birth, you kind of see a problem here. So that you might hear about, after the fact. That really is inappropriate. So when it comes to radio reports, and specifically I'm talking about giving a radio report to a hospital as you're transporting this patient there. So you're giving a full report of what's going on with the patient, what you found, and all those things. This really is a learned skill, just like anything else you've learned so far in this class. You're going to have to learn how to be good at this, whether it's patient assessment or obtaining vital signs. It's equally important to have a good, effective report over the radio that paints a clear picture of what's going on. And why this is so important is if you don't express to the radio nurse or to the physician that you're talking to exactly what's going on, they're not going to be able to help you with advice and or even medications that you might need because they might not understand exactly what's going on. So it's important that you present your report in some kind of organized way, cover the really important points, uh, and get it done in a fairly brief and effective way. The way you start with this is once you've gathered whatever information you have from the patient and their physical assessment, you'll usually have it written down somewhere, a piece of paper. It could be on a tablet and you've typed it into a program. You might have it even written on the back of your glove, whatever it might be. Look over the information. Give yourself 10 or 20 seconds to look it over. Try to prioritize what's really important. Organize your thoughts in your head. And then get on the radio and start the process. You do need to include the ETA to the hospital, how bad off your patient is, the level of acuity, any really pertinent findings that is going to paint a better picture and maybe give the doctor and or nurse a better idea of what's going on. Any treatment that you've provided so far, and of course how the patient has responded. And of course you can also ask for further treatment by base hospital order. When we are speaking to the hospital on the radio, it's going to be in plain language. We're going to use common medical terminology and common abbreviations that everyone knows. When it comes to using medical terminology, if there's a medical term that you just can't pronounce, or there are some medical terms that they might have two or three different medical terms, they kind of all sound sort of similar, especially on the radio. If you're concerned about good communication, you can spell those words, and it really helps a lot, especially with the radio transmission and all that. If you're talking about numbers, for me, it seems to be the age is the big issue here. So if you're going to express numbers over the radio, especially the person's age, do it in the single digit way. So rather than 16 years old, you want to go 1-6, or 60 years old, 60. Sometimes these things can sound similar over the radio, and they're obviously diametrically different patients. Make sure you're on the right frequency. So once you turn on your radio, you set it to the frequency that you want, the hospital that you're trying to contact. You hit the push to talk button. You hail them. Hey, Mercy, this is BLS 25. Are you guys open for patients today? Let go of the button, and they'll talk back to you. Now you know you're on the correct frequency. Once you are talking and getting that established, and you're making sure you're in the right frequency, they're going to want your agency name, your unit number, and your level of care. So you might want to say, Mercy, this is AMR BLS 25. We have a mild status medical patient requesting your facility. We have an ETA of 10 minutes. Are you open to accept? Let go of the button, and then they can answer you. So you've covered all of those points. They know what you've got. They know you got the ETA. They know the status of your patient, who you are, and all that great stuff. Once you're going through your report, at some point you might be asking for additional medications, more epinephrine, maybe another dose of nitroglycerin. When the nurse or the doctor gives you the order for the medication, the additional dose by base hospital direction, you're just going to echo it back to them so that there's no miscommunication, that they understand, that you understand the exact dose and the route of medication and all that. And once you administer that medication, you're going to reassess the patient, and then probably more than likely call them back briefly and give them some kind of update as to whether the patient got better or worse or whatever happened. If the doctor or the nurse, gives you an order over the radio that doesn't make any sense, the dose is wrong, the route is wrong, something's weird, you can always, be professional and be courteous, but just say, excuse me, just confirming, and then just repeat what they said and say, are you sure this is right, this is correct? And then work it out with the physician or the nurse at that time. Even if the dosing is correct and the medication might be appropriate for the patient's condition, sometimes the patient might not be able to tolerate it. If you feel in your, in your capacity that you don't think this patient might not tolerate this, you can decline that order, but be respectful and explain clearly why that is. So for the purpose of the 105 class, this document right here is going to be your template for providing your radio reports. And if you look at it carefully, you'll notice that if you fill this out with the information that you've acquired from your patient assessment and the other demographic information, if you read this top to bottom, left to right, it actually reads out like a fairly decent, organized radio report. This is a great starting point for you guys. Once you have this format sort of in your head, then you can find your own style, how you want to present it. But it does need to be really organized and obviously brief and definitely to the point. So you've already communicated with the base hospital or the hospital wherever you're going. and they're going to accept the patient. They said, "Come on in." So you hang up the radio, so to speak, and en route to the hospital, you're reassessing your patient, you're providing treatment and all that. You're going to get to the emergency room, and you're going to turn the patient over to a physician or a nurse, an RN, which I know you guys know about that already with this. And the way this is going to work is if you have a mild status patient with a mild condition, you're probably going to have a nurse at the bedside, and the nurse is going to take your report. And they're pretty, what's the word for it? They're willing to listen pretty much to what you're going to say. My recommendation is to take your radio report and trim it down to something that's manageable for about a minute or so, maybe a minute, 2 minutes of talking, and include any updates that might have occurred, after you stop talking to the base hospital, something that happened en route to the hospital. If the patient is moderate to acute status, CPR in progress, severe respiratory distress, severe trauma, there's going to be a doctor at the bedside as well, and the doctor's going to want to hear your story. The one thing about the doctors, there's a lot more nurses than there are doctors in the emergency room. So the doctors are kind of juggling like 10, 12, 15 patients at a time. So all they want to know is like the highlights. So they might stand there for 30 or 40 seconds. They hear your story. They get a general idea of what's going on. They give the nurses a few orders and they walk away. Don't take it personal. They're not ignoring you. They're just so busy. They need to just keep moving because they have all these patients to work with. Taking charge. Okay, so when someone calls 911, they've got a problem. And everyone's got a different perception of what a problem is and how bad it is. So when a person calls, it might be the worst day of their life. And they call us because they want us to come and help them and to solve their problem to whatever degree it might be. So when you arrive on scene, you really need to take charge of the scene, to bring some kind of order to whatever chaos is going on. And what this does is it helps to kind of relieve some of the stress that the patients, the bystanders, the family members, whoever might be there, because they see someone's there, they're in charge, things are being done in an orderly manner, and things are progressing, and they feel better, and it makes them feel better, and it improves our communication with whoever's there at scene. So when you arrive on scene, you need to act confident, talk in a calm voice at all times. Please and thank you goes a long way on these calls, especially the really acute calls with the really sick patients, the CPR that you might run on, the critically injured trauma patient, the pediatric who's really sick. Everyone's going to be really heightened tension, and it's going to be a very dynamic scene, and people are going to be kind of really nervous, even the fire crews and even the other EMS crews, as well as the family. If you're in charge and you talk calmly and use please and thank you and be kind and courteous to everyone within reason, it really takes down that tension quite a bit. People feel like, okay, so now we can proceed, at a more steady rate, and let's step back a little bit on this one. It helps a lot to do that. So just as a reminder, we might have mentioned this already, any kind of reporting on the radio or in documentation on your iPad is going to be military time. So there's the military time right there. It should be hopefully self-explanatory. Principles of good patient communication. So ultimately, to communicate properly with a patient and to get the information that you need from the patient, you need to build a rapport with them. You need to basically build some kind of bridge of communication with them. And there's a lot of different reasons why this can go sideways. It's unfortunate. I see a lot of EMTs, a lot of paramedics out in the field, and they probably should not be in medicine. they don't have the personality, they don't have the communication skills they need to effectively build this bridge of communication with their patients and make the patients feel better and obviously makes the call run better as well. So I know you've heard about the term first impressions, and first impressions are really important in private life as well as in EMS. Now, as you're walking up to the patient, to your 10, 15, 20 feet away, you see the person, you see how they're presenting, and in your mind, you can immediately get a snapshot of stable or unstable. And usually those first impressions, stable, unstable, whatever it might be, are pretty accurate. Because you see this person, they're sitting up, they're lying down, their eyes are closed, the skin's kind of bluish color, it's pink, whatever. It's a pretty good impression. And this also works pretty well in your private life as well. You meet somebody that you just don't like immediately, you've never met them before, and that's your first impression. It's usually pretty accurate. Introduce yourself. Obviously, hello there, I'm John, I'm an EMT, I'm here to help you. What's your name? Where are we right now? What day of the week is it? Go through those steps. Get down and make eye contact with them if that's safe to do so. And ideally, if you can touch them, meaning to check their pulse or put your hand on their shoulder, whatever's appropriate for the situation, it really helps a lot to create a bond with your patient. Speak clearly and always use that professional tone whenever possible. Very rarely will you have to raise your voice in a kind of a command voice. It does happen sometimes with, especially people who are really, really drunk, or sometimes psych patients as well. You might have to do that to control them. But in pretty much 99% of the time, calm, professional voice, being courteous and kind and please and thank you helps a lot. And most importantly of all of this is listen to what they have to say. You're asking questions. You're trying to decide what's going on today, and you're asking questions. Listen to what they have to say. It might give you some clues. And again, I see a lot of people out there working, medics, firefighters, EMTs, even doctors and nurses do this. They ask a question, and they don't listen to the answers. And trust me, people are not stupid. These patients, they see you're not making eye contact. Your hands are in your pockets. You're looking around. You're not really paying attention to what they're saying. You're asking the same question twice. I mean, all those are clues to this particular person that you don't really want to be there. You don't care about them. And it's really going to screw up your whole assessment. Asking questions. So you ask the person questions. Obviously you've learned about sample history and other special questions that we talked about. But you want to start out at what's called an open-ended question. Simple as, I'm John, I'm an EMT, I'm here to help you. Why did you call us today? So then this person says, I have chest pain. And then once you have a chief complaint, then you can ask more questions, more closed-ended questions. Are you short of breath? How long has your chest pain been going on for? And you can work your way down this flow chart until you have an idea of what's going on. But again, you have to have this, you have to gain the confidence of this patient, make them feel like you're interested in them, which you should be really, and so they'll talk more freely to you and be more more honest with you. If you do have a hostile patient, I'm not talking violent patients. The violent patients, you should be leaving the scene and calling the police. But someone who's yelling at you, calling you names, saying derogatory things about you, you got to think about a couple of things. First, you've never met this person ever before in your life, and you walk up and they start saying bad things to you and about you. Don't take it personally. They're just trying to get you to respond to them in kind. They want to yell at you so you can yell back at them. They're trying to get a rise out of you. The best way to deal with this is to literally, or I guess figuratively, kill them with kindness. Calm voice, sir, ma'am, please, thank you. explain why you're there. Another thing about hostile patients, whether it's alcohol or drugs or a psychiatric patient or other reasons why people have these issues, is they usually develop a really big personal space. So I would probably get about 10 feet away from your patient and explain who you are. Hi, I'm John. I'm an EMT. I'm here to help you. Your friend said you're not feeling well today. You took some medications that might be affecting you. I'm not a police officer. I'm here to help you. So you're 10 feet away. You're expressing who you are. And it's possible you could talk them down to the point where they could maybe have you come a little closer, do some kind of assessment, maybe even touch them if possible. But it's going to take you a while to gain their confidence and calm them down to the point where they're willing to accept your presence. Just be careful. So when it comes to asking questions, the big thing here is you're going to ask a question and they're going to try to answer it. With small children and older patients, geriatrics, they have a tendency to kind of go off the rails a little bit. You ask this gentleman here in the picture, sir, I know you have chest discomfort right now. Are you short of breath? And they start talking about something that happened in 1976, and it's not really pertinent to today's situation. So in a very nice way, you're going to kind of get them back on the track. Sir, I'm really sorry that you had that condition back in 1976, but you called us today for this chest discomfort. Can we talk about that? What's going on here and now today? And again, if someone says, "Am I going to die?" Well, you don't really know, so you can't really say yes or no. So just say, we're really not sure right now, but we'll get you to the hospital as soon as possible. So just don't say, oh, you're going to be fine, because you don't know. So nonverbal communication. You'll notice this picture right here. This EMT in the uniform right there, his arms are crossed. He's standing over the patient in a dominant position. You can tell he's already angry. She can tell he's already angry. She's got her hands up in that defensive position, and the call's already going sideways. So the one thing you don't really want to do is obviously not be aware of your body language. You shouldn't have your posture like this, in this domineering posture with the arms crossed. You shouldn't really even have your hands in your pockets, because that's just expressing to the patient that you don't care. You don't really want to be there. You'd rather be somewhere else. You're not really interested in what's going on. And again, there's that distance issue. Obviously, if this call had gone differently, this EMT would have probably knelt down in front of this patient within a few feet, started talking and what's going on, taken her pulse, found out what's going on, and the call would have gone right. But because he's being more aggressive, their communication is going to be it's going to be trouble getting anything out of this lady and getting her the care that she needs. So when it comes to other types of circumstances, they're pretty rare, but we do run into them. So when it comes to the elderly population, putting aside dementia and Alzheimer's and other types of organic brain disorders that we run into with this age population, even if the patient is fully oriented, they could have hearing problems, they could have vision problems, they could have speech problems from maybe a stroke or something. So communication might take longer with these people, harder to get the information across. A lot of times it can be really evasive as well. EMS and hospital and fire and doctors and nurses can be really scary for these people, and they have a tendency to downplay things because they don't want to go to the hospital because they're afraid they might lose their independence. When it comes to different cultures, we have, San Diego is really diverse. You probably already know that with this. And over the years, I've learned the hard way, unfortunately, that every culture is different. And, if you work in one kind of geographical area, you become familiar with that culture in that area. So it might be a Somali population. It could be there's a lot of Russians. We have a lot of Russians and Ukrainians in the city, and of course, Hispanic population, Asian populations. I mean, there's all kinds of dozens and dozens. I can't even imagine with this, and they all have different cultural, norms that differ from maybe yours. I know one in particular that I've run into a few times with people who are devout Muslims. I've had patients, female patients, that even though they had a serious medical condition, their families told us that we were not allowed to touch, because we were male first responders. We're not allowed to touch this female patient. That gets complicated sometimes, but just be aware, just honor this, and maybe you could maybe call in a female EMT or something like that to work out to treat this person. So just be aware that what you do, what you say, what they say, how they present. Uh, you're going to have to over time learn how to accept this and also work around some of these limitations when it comes to us treating the patients. Little kids, of course, when they get old enough, like this little girl right here, they're old enough to talk directly to you with the help of the mother and all that. Keep it simple, make eye contact, ask them permission, because, this little girl's probably about 4 years, 5 years old or so. She's old enough to say yes or no, and she's old enough to understand what's going on. So ultimately, that's pretty much it. I think we're all done. See you in class.